Hi, all. Thanks for joining us. We'll just give it a minute as folks join the Zoom room. Well, I think we have critical mass. We'll go ahead and get started. Hi, all. My name is Jason Resendez, and I'm President and CEO of the National Alliance for Caregiving. And it's my pleasure to welcome you to this webinar as we present findings from a brand new report published today, Transplant Caregiving in the U.S., a call for system change. This report highlights the experiences of an often unseen community of family caregivers, those who provide care for someone waiting to receive an organ, stem cell, or bone marrow transplant who have received these life-saving procedures. Transplant caregivers play a vital role in the lives of organ transplant patients. They provide essential physical and emotional support before, during, and after surgery, and their contributions are critical to the success of a transplant process. Now, despite the importance of transplant caregivers, relatively little attention is paid to their experiences and needs. This report aims to address this gap by providing a comprehensive overview of the transplant caregiver's role, the challenges and rewards of caregiving, the impact of caregiving on the caregiver's life, and also it makes recommendations for improving supports for caregivers through policy and practice change. This report is based on a review of existing research and interviews with transplant caregivers, healthcare professionals, and subject matter experts. The findings reveal that transplant caregivers face many challenges, including significant time and effort commitment, high levels of stress and anxiety, and an overwhelming lack of support across the care continuum. As one caregiver told us, it was a nightmare, and I was shocked that I wasn't better prepared via the hospital. And when you leave, it's like the door gets shut. They're so busy with the patients that all they have, and there's no one there. There's really no one. By centering these kinds of experiences across transplant care and treatment, we can do better to support family caregivers who are part of this essential process as partners and navigators in dealing with complex care. It's our hope that this report sets in motion a series of additional actions to shift the perceptions and actions of health system leaders, policymakers, patient advocacy organizations to step up and to do more and to do better in support of family caregivers within transplant care. And I know that we can do that with the support of all of you in your partnership and collaboration moving forward. And as we work to advance this effort, the National Alliance for Caregiving is dedicated to centering the lived experiences of family caregivers. Family caregivers like Ira Cooperman. Ira and Glenn Daggert began their caregiving and care partner journey in 1976. Since that time, Ira has focused his public efforts on promoting and supporting the patient and family voice in the transplant community. Ira is a member of several local transplant patient support groups. Locally, Ira is the public member of the Medical Advisory Board for Live On New York, the New York-based OPO. On the state level, he is a member of Donate Life New York State Advisory Council. Nationally, he is vice president for the Transplant Recipient International Organization, TRIO. In addition, he has been a public interest member for the congressionally funded Department of Defense's research grant program, as well as Mathematica's patient focus group activity. Finally, Ira participates in several grassroots efforts on behalf of transplant patients and families. Ira has been a tremendous partner, a resource, a motivator in our work to shift systems to better center and address the needs of family caregivers in the transplant process. So over to you, Ira.
Jason, thank you very, very much. And I'm just very pleased and gratified to participate in this program. Hello, everyone. I am the very, very happy spouse to Glenda Daggert, who is a 24-year transplant recipient of a simultaneous kidney and pancreas from a deceased donor here in New York City in 1999. We are, of course, always grateful to the surgeons, the doctors, the nurses, the hospital administrative staff, the OPO here in New York, and of course, our donor whom we think about every day. But we do think we've come to this point of 24 years of success uh, through our own personal commitment to making sure everything is going right. We had a very, very mutual view of what caregiving was a part in, and actually, we do prefer to, between the two of us, we call it care partnering, because Glenda is as much a care partner to me with what I need as I hope I have been to her with what she needs. So that's what I'm here to talk about today. Some of the ideas we've applied to make our long-term journey as good as it has been. Our first step is education. And by that, I mean that our education, our personal education, began well before even Glenda had a transplant. Glenda and I met when she had a chronic disease, diabetes, and had been had diabetes for many, many years. This is, of course, the diabetes which led to her transplant in 1999. But our education to make sure that we were doing all the things we needed to do while Glenda had education began from the day we met and continues today. Education is not a closed process. It continues to go on today. We read, we attend lots of lectures about transplantation and about kidney and pancreas activities. And it was a very, very important commitment to making sure that goes on. In fact, for every one of our doctor's appointments, Glenda's coming to my appointments, my going to Glenda's appointments, we sit at the dining room table and create our list of questions for the appointment that day. The second point that I think is important for us that's worked well is advocacy. Personal advocacy on my part, and on Glenda's part for me, but it continued. It had to start actually, though, within a couple of days of Glenda receiving her transplant back in 1999, when I found myself at the hospital making sure that Glenda's care was the appropriate care she deserved and was supposed to get to make sure that her recovery journey was as successful as it was. So advocacy on behalf of your spouse, your partner, whoever it is a very, very key, important. We've had over the years a number of issues with Medicare and drugs and prescriptions and insurance companies, which I'm sure everybody has, but we've applied our own personal advocacy and involvement to getting those issues resolved, leading very, very much to Glenda's success. From this, we've also learned that we have a responsibility. We have a responsibility to participate in grassroots efforts at all the various levels of government on behalf of the transplant community. We started that back very, very early, within less than a year of Glenda's transplant, and it continues unabated with our participation in a number of grassroots efforts that speak on the needs of the transplant community and transplant patients, as well as, I hope, what comes out of this program for transplant caregivers and care partners. We believe in a constant interaction with our transplant center and with all of the participants in our medical care. That includes with talking with them. As I said, we make lists. We have everybody's email. We have everybody's text. We have continued that coordinated approach to transplant care, pre-transplant, post-transplant. In fact, all of the doctors whom Glenda has, that she goes to for the long-term care of various issues, are coordinated with her basic transplant team, her follow-up nephrologist, who gives us all of the references to every other ologist you can think of. What I found was that this became very important during the COVID crisis, when early reports didn't even consider the needs of the transplant community. So we really had to reach out to other places, and we're very grateful to some other centers that stepped up outside of our own. Our own did not do a very good job of attending to the needs of the transplant community during the early days of the COVID crisis. So we had to step up and find places to fill the gap. We've learned a couple of lessons from this. We think that they apply, and that ongoing improvement for transplant caregivers, for maybe even for caregivers of all kinds and care partners, but certainly for transplant caregivers. I wish early on, for example, that my transplant hospital had offered a course in just note-taking, so that when Glenda and I went to an appointment, I would know how to listen to what were the important things that the doctor was saying. I was furiously writing down what we did, and then Glenda and I spent a fair amount of time making sure we understand what the important changes were that he was asking for, or the important things that we had to do between then and the next appointment. I wish the hospital had given us some pointers and some direction to support groups, because the support groups, we later came to find on our own, are incredibly rich resources for support, for caregiving support, for emotional support. Forget even the medical support, which they offer in abundance to each other. Not that they give medical advice, but they always can give you their own personal experiences, which you can draw on. And finally, I wish that the transplant centers had pointed us to the right places to get all kinds of medical updates. Where do we go for the latest information about our transplant immunosuppressive drugs? Where do we go for the latest changes to the way drugs are administered, or the new forms of drugs that we needed? All of these kinds of practical things, which are ongoing. They don't end the day you get a transplant, the week you come home from the hospital, the couple months after you've been to your very numerous appointments. This is an ongoing process which occurs day after day, year after year, and has contributed, I think, in no small way to our long-term success with a 24-year transplant. So thank you very much for your time today. I appreciate the opportunity you've given me to share our experiences with you and with this entire audience. Jason, thank you very much for including me in today's activities.
No, thank you so much, Ira, for helping to anchor our discussion and your lived experience and reminding us and previewing some of the themes that you'll learn a little bit more later in the report, from insufficient and fragmented support across the transplant journey, the opportunities that exist for centers to step up and provide more comprehensive and more caregiver-centered support, and the integral link between caregiver support and patient outcomes. So thank you so much, Ira. We appreciate your insights and your advocacy along with your wife. I want to also recognize that this work wouldn't be possible without the financial support of our sponsor, Takeda, While the content and opinions expressed in this material are solely those of the National Alliance for Caregiving, Takeda's sponsorship made this work possible. So thank you so much to Takeda for their support of this ongoing initiative in the transplant space. I now want to turn it over to my colleague, Yadira Montoya. Yadira's work focuses on advancing health, equity, and racial justice. She's the program director for the National Alliance for Caregiving. She has over 15 years of experience across multiple sectors, including academia, nonprofit, and philanthropy. In 2019, she was recognized as a culture of health leader by the Robert Wood Johnson Foundation for her leadership in community efforts to improve aging equity and the health and well-being of Latino family caregivers navigating dementia. We're grateful and excited to benefit from Yadira's leadership, including on this project. So over to you, Yadira.
Thank you, Jason, and good afternoon, everyone. It's a pleasure to be speaking with you. One housekeeping note before I get started. We're going to be holding a Q&A session at the end. So if you have any questions, please write them in the chat or enter them into the Q&A box so that we can answer them after the presentations. Not a housekeeping, but just a context. There's a lot of ambulances going around me, so hopefully you do not hear them, and if you do, I apologize. So as we heard from Ira's personal story, care partners and caregivers really provide essential support, advocacy, coordination before, during, and after surgery, way after surgery, in the case of Ira, decades afterwards. And there's a whole gamut of resources and information that is needed to help them carry out this work. He mentioned the need for practical tools and resources that would have been useful to navigate the healthcare system, to staying up to date with medical information, as well as early connections to supports external to the healthcare system, so outside in the community. And like Jason said, really preview what we've learned through our work. So despite the importance of cancer caregivers, as Jason has mentioned, relatively little attention has been paid to their experiences. What I'm going to be presenting are the key takeaways from our research and recommendations for improving support for family caregivers and care partners. Next slide, please. As part of this report, the National Alliance for Caregiving conducted a literature review. We convened a subject matter expert panel, held focus groups with family caregivers, and collected oral histories with them. First, we reviewed 81 peer-reviewed journals, original articles, and systematic reviews. We then used these articles to analyze and identify cross-cutting themes, which I will be presenting in the next slide. We engaged a panel of 10 subject matter experts representing the transplant ecosystem. They participated in a survey and a panel discussion. And we also talked to a diverse group of transplant caregivers across the country. This diversity was across age, race, and ethnic background, income status, geographic location, sexual orientation, gender identity, stage of the transplant process, as well as relationship with the transplant recipient. We partnered with the Cheisler Group to conduct 5 two-hour focus groups with 30 caregivers. The focus groups examined the transplant caregivers' experiences, difficulties, supports that they received, barriers to getting that support, as well as suggested solutions from the caregivers to address the barriers. And finally, NAC conducted oral histories with 12 caregivers. We spoke to each of the caregivers for 60 minutes about their day-to-day experiences being a transplant caregiver. Each story was summarized into a written vignette that's in the report, as well as we also created short videos. And throughout all of these activities, we work with an advisory committee. The advisory committee was comprised of 10 members with lived experience and or subject matter expertise in transplant, patient engagement, and advocacy. They provided input and feedback on all of the phases of the project, from helping with the logistics as well as reviewing the results of the project. Next slide, please. In our literature review, the three main questions we were trying to answer were, what are the experiences of transplant caregivers from pre-transplant to post-transplant? What are the challenges they face, especially post-transplant? And what interventions have been developed and evaluated for transplant caregivers? Our review revealed three cross-cutting themes. First, caregivers may experience mental health challenges at any point during their transplant journey, from diagnosis to the waiting period to or leading up to and right after the transplantation. These mental health challenges include stress, burden, fatigue, anxiety, depression, worry, and even PTSD. This distress not only has a negative impact on the caregiver's day-to-day functioning, but it also impairs their ability to carry out their caregiving responsibilities, thus potentially impacting the patient outcomes as well. Despite facing diverse mental health challenges, transplant caregivers also encounter positive outcomes. We learned that there's literature that shows that caregivers have a heightened ability, some caregivers experience a heightened ability to appreciate the present, to be present, feelings of honor and pride, and a deeper personal and spiritual connection to those who they were caring for. The second major theme from our literature review was equity. While the impact of caregiving is difficult and demanding, not all caregivers or transplant recipients experience the same challenges. Our report found that the burden of transplant caregiving is inequitable, with caregivers from socioeconomically disadvantaged and or diverse racial and ethnic backgrounds face a disproportionate burden. An area of inequality is the cost of the transplant, especially for caregivers who may be on a limited or fixed income. And we learned that housing, transportation, medical expenses, and the loss of earnings from changes in their jobs due to the caregiving quickly accumulated and contributed to caregiver financial strain. Lastly, in terms of current transplant caregiver interventions, most are centered around transplant-related education for both the patient and the caregiver. There are some additional efforts that target the mental health support of the caregiver, employing stress management techniques, problem solving, and peer support. However, this literature is scarce in stress management. Despite the scarcity of this literature, stress management and education interventions have been shown to help boost caregiver confidence and mitigate psychosocial distress in caregivers. The existing interventions, while beneficial, highlight the critical need for more comprehensive research to understand and develop effective strategies to address the mental, emotional, and social health needs of transplant caregivers, particularly of socially, culturally, and economically diverse caregivers. Next slide. When we engaged the panel of experts, which it included patient advocates, social workers, clinicians, pharmacists, and financial coordinators, we engaged them to understand the pre- and post-transplant practices, resources, and supports. We learned that in general, resources and supports at the centers were for the transplant recipient, which meant that caregivers were offered what was available. And if this broad approach that isn't individualized or intentional resulted in limited or declining support unless the patient spoke up on behalf of their caregiver or the patient missed an appointment because of an unmet caregiver need. The table in this slide maps out the resources the panel identified as available, along with the suggestions for what's needed in terms of supporting caregivers. I know it's a busy table, so I'll just point out a few things that the panelists indicated. So the development and dissemination of caregiver-specific educational information and resources that acknowledge the critical role that the caregiver was playing and would be playing, as well as adequately preparing them for the complex and ongoing requirements of being a transplant caregiver. This most often referred to the medical and nursing tasks that the caregivers would have to perform at home. And then there is also the financial assistance resource where the caregivers cited needing help with the out-of-pocket medical costs, healthcare coverage gaps, as well as loss of income due to their taking on their caregiving role. And finally, the need for evaluation and psychosocial support, referrals and linkages to support services within the healthcare system, within the as well as outside. Next slide, please. The panel of experts illustrated the challenge of the transplant journey. Illustrated two main takeaways of this challenge two main takeaways. So first, the resources available to transplant recipients and to transplant patients and caregivers during the pre-transplant phase is limited. However, we also see a dramatic decline after transplantation. Second, the transplant system can and should play a bigger role in establishing caregiver support and resources. Things like education and training on transplant complications, infection risks, medication adherence, medical and nursing tasks are some of the areas that have direct and important implications for a transplant recipient's recovery and quality of life. Next. When we spoke to the family caregivers, our conversations, or what they shared, were reflective of the literature and the subject matter expert observations. Our conversations with caregivers revealed that they are under-resourced and under-supported throughout their transplant journey. This slide shows the top areas where additional support is needed. Caregivers reported that the requirements, information, and communication surrounding the waitlist was confusing and frustrating. Transplant caregivers and those they care for often interacted with multiple transplant centers to find a transplant match. The lack of universal screening process that made the transplant process more difficult to navigate and created barriers for the caregivers. They also describe how their mental and physical health were compromised throughout the transplant process. Caring for the transplant recipient meant that they often deprioritized caring for themselves, and their health often fell by the wayside even when they became ill. Accessing and navigating the healthcare system was another major source of stress. Caregivers spoke about the challenges understanding the health insurance coverage, Medicaid, and Medicare benefits as it related to the transplant surgery, as well as the additional healthcare medical care that their recipient needed. Caregivers of family members with Medicaid insurance shared that they perceived that the quality of care they received was lower, making the process even more difficult for them as they struggled to get their family member everything that they needed. Caregivers also spoke about the financial strain they experienced. They spoke about the difficulty staying employed while managing their caregiving role. And for those caregivers who identified as middle class, they noticed that they could not afford the cost associated with the transplant, but they were also ineligible to qualify for the financial support because of income requirements. Caregivers found it difficult to receive timely and relevant information related to navigating the transplant process and about the transplant process. Often they did not know what to expect next as the recipient moved through the system, and they also noted the need for culturally and linguistically relevant educational resources. And finally, caregivers shared that support was available early on in the process, most noticeably when on or attempting to get on the waiting list. And once in the system, the care recipients team was very communicative about and would make them aware about the transplant process and expectations. However, there was a noticeable drop-off in support from the healthcare team, ranging anywhere from 3 months to 1.5 years post-transplant. They would find that their medical team was smaller with less resources available to them, and that they would be receiving fewer medical updates. And in terms of what was helpful, they shared that the most that support groups was the most widely cited support available. Whether virtual or in person, they provided the emotional support that caregivers needed and were seen as safe spaces. In the interest of time, I'll just go highlight this caregiver oral history. It's Yan. She is a caregiver for her son. And this slide talks about the impact of caring for her son, even though her son received, it's been years since her son has received the transplant, a heart transplant, as well as the impact on her mental health status as being a transplant caregiver. We have developed, as a result of the literature review, the consultation with the subject matter experts, and talking directly with transplant caregivers, we have developed recommendations to help ensure that caregivers are provided with the necessary supports and services throughout their transplant journey. Next. While having a caregiver is a requirement to be waitlisted in most transplant programs, there appears to be no consistent screening process across the transplant centers. A standardized screening process would help provide transplant patients and their caregivers with the opportunity to be added to the waitlist, regardless of their race, ethnicity, or socioeconomic status. It would also delineate necessary requirements to be applied across transplant center. Caregiver identification is a critical first step toward documenting, understanding, and addressing the challenges of caregivers. Next. Transplant caregivers and patients engage with multiple centers simultaneously, as I shared. Efforts to facilitate efficient information exchange between the centers would alleviate stress and save time, particularly when relisting patients previously removed from health because of a health issue. Streamlining this information and the sharing among transplant centers would alleviate the stress for both the caregivers and the patients navigating this complex process, which is already emotionally taxing. Next. Introducing a designated caregiver coordinator within the transplants team would provide who can provide ongoing support, information, and resources, and help address the caregiver's needs is necessary to prevent issues before they escalate. The Center for Medicare and Medicaid Services should develop new reimbursement pathways to incentivize healthcare providers to train and support family caregivers in providing the complex medical tasks associated with transplant care. CMS recently issued a 2024 Medicare physician fee schedule proposed rule to reimburse healthcare practitioners to provide caregiver training. This rule should be adopted and leveraged across transplant centers to support training and support services targeting family caregivers. Next, transplant caregiving can be very demanding, as we've heard from Ira and from our report, both physically and emotional. Caregivers provide around the clock care, and they juggle this caregiving responsibility along with work and family. Routine screening would ensure that family caregivers receive essential education and information early, and that they are matched to supportive resources, and that supportive resources are matched to individual caregiver requirements. Next. Finally, we need policies that provide financial assistance, workplace protection, and comprehensive medical coverage for transplant caregivers. Federal policies like FMLA offer job protection, but fall short of providing necessary income during the necessary income during the leave, highlighting the need for a national paid family leave policies. Strengthening Medicaid and other federal policies would also alleviate the financial burdens, as disparities in coverage for caregiver expenses persist despite Medicaid, besides transportation, meals, and lodging being covered by some programs like Medicaid. So thank you all so much. I want to turn it over now to Dr. Allison Applebaum, who will be sharing her perspective as a provider, as well as the lessons learned from the HCT space and how the recommendation share information from a paper she recently published with colleagues about how healthcare systems can support caregivers for patients across all transplant type.
Thank you so much, Yadira, and thank you so much to the National Alliance for Caregiving for having me. It's such an honor to be here. I'm a clinical psychologist by training, and my work has focused over the past 14 years on addressing the profound psychosocial needs of family caregivers. And today, I'm going to be reflecting on the recommendations that Yadira shared and some additional ones that I and my colleagues have been discussing to better support the needs of caregivers such as Ira. Next slide. Just need to acknowledge my disclosures. Next slide. I want to start with an anecdote, and that is when I came to this work in 2010, one of my first consults that I received was from the bone marrow transplant service at Memorial Sloan Kettering Cancer Center. They were about to initiate their pilot trial of their outpatient and homebound hematopoietic stem cell transplantation protocol, and they wanted me to review their materials. And when I looked at the consent form, I saw that it said that in order for a patient to enroll, the patient needed to have a caregiver available 24 hours a day, 7 days a week for a month. And I thought to myself, what an extraordinary responsibility we are placing on the shoulders of family caregivers. And if we are doing that, then it is our responsibility as a healthcare system to support and train and educate those very caregivers. If we don't do that, up to 50% of caregivers experience anxiety, up to next, 42% depression, next. Many experience PTSD. So many caregivers experience insomnia, and this insomnia is both precipitated and maintained by caregiving responsibilities. It makes it so very difficult to carry them out. The distress experienced by caregivers is profound, and we know that rates of suicidality are actually higher in caregivers than in the general population. And it's very important for us to acknowledge that the distress associated with caregiving does not end with the death of the patient, and many caregivers are at risk for what we call prolonged grief disorder. Next. We know that when left untreated, this distress will increase exponentially across the caregiving trajectory. Next. We also know that there are particular points in this trajectory when caregivers are at unique risk for distress. And in the transplant period, these include not just the period of transplant, next, but also a period of recovering survivorship. I know that Ira's stories and those that were shared in the report really underscore the fact that caregivers need support long after their loved ones receive their initial period of care. And this is an area where we as a field are really missing the mark, and where I think we can take great strides in improving the quality of life of family caregivers. Next slide. So last year, a group of colleagues and I from the American Psychosocial Oncology Society published this article, Fit for Duty, where we discussed the lessons learned from our outpatient and homebound stem cell transplantation programs to create recommendations that would help all caregivers, that's all of us, taking care of patients at home. And I'm going to reflect on 5 of these recommendations today. They're very much in line with the recommendations of the NAC report, and I think that they are absolutely feasible and achievable in the near term. So to start, the first recommendation, next, is to identify and screen family caregivers. Next slide. So number 1, we obviously need to identify caregivers as early as possible, and via the CARE Act, this actually should be happening as soon as patients present to the healthcare system. But early is great. And second, not only should we be identifying a family caregiver as that consent form asked us to do, but we need to be evaluating their fitness for duty. Are they able and willing, most importantly, willing to fulfill this role? Are they physically capable of doing so? Are they, next, are they cognitively capable of doing so? Next. You can keep going, Lauren. Do they have past experiences with caregiving, and are they willing to take on the role again? Do they have any current or past mental health challenges, and are they in mental health care themselves right now? And will that impact their engagement in care? Very importantly, very infrequently is the health and safety of the patient and care partner relationship assessed. And too often, caregivers are tasked with taking care of individuals with whom they have very difficult and even abusive relationships. And it's going to be very important for transplant teams to evaluate the safety of that relationship before asking a caregiver to fulfill that role. It's also important to evaluate the cultural factors that may be impacting care. For example, is the family's native language that which is spoken by the medical team? And if not, are steps being taken to deliver materials in an appropriate manner? Similarly, we must evaluate existing resources and social determinants of health. If we are asking families to come to our treatment centers week after week, even day after day, we need to make sure that doing so will not prohibit them from putting food on the table. And finally, while screening absolutely needs to happen pre-transplant, it also must happen post-transplant and repeatedly into the period of recovery and survivorship, as we know this is a time when caregivers are at high risk for distress. Next slide. So for each of these, I'm going to talk about potential pitfalls and solutions. Lauren, you can put them all on the screen. I'm going to highlight a few of them for you right now. Of course, when we say we want to have our teams screen for all of these facets of well-being, well, then of course we potentially increase clinician burden. There's a lack of clarity about who's actually going to do this screening. And we remain in a mental health crisis in this country, where we have a lack of trained mental health professionals, especially housed in our healthcare systems. And certainly when screenings identify caregivers in need of support, we need to route those caregivers to appropriate levels of care. Very importantly, these screening protocols can logically be fit into patient protocols, and so that when patients meet certain treatment milestones, that will trigger a screening for a caregiver. Next slide. There are also tools such as those from the cancer support community. This one's called the Cancer Support Source Caregiver, forgive me. This type of tool actually can help treatment teams to do their job. It will very quickly identify caregivers who are high risk for distress, for depression and anxiety. It's multidimensional and evaluates many of those factors I identified in that previous puzzle, and allows for teams to build in information on the back end. And so in many ways, does some of that work for the treatment team. Next slide. The second recommendation is the development of an infrastructure to support the documentation and storing of family caregiver data. Next slide. And you can just click through all of this, Lauren. So here we are, we've conducted all of this incredible screening, but if we do not have a repository, a place to put this screening data, then how valuable is it? And I and my colleagues have advocated that the caregiver should actually have their own medical records in which we can put this screening data. This would then allow for ethical billing practices. If, for example, screening data showed that caregivers are really distressed and need support from a clinical psychologist for myself, well, then if I see that caregiver, I can bill for that service ethically by documenting that caregiver's data in that caregiver's record. There's no confusion over who the patient is. There's no confusion over, no concerns around privacy or confidentiality. For sure, many caregivers do not want their partners in care to know how distressed they are. And many don't want them to know that they're under my care or the care of my colleagues. And so having separate records can assist with maintaining privacy and confidentiality, and it can facilitate care into bereavement in the case when patients die. Next slide. Now, certainly one of the challenges I've heard in terms of implementing these types of records is limited buy-in from institutional leadership, in part because we are already existing within an overburdened healthcare system. And here we are saying, well, here are many more patients for you to enroll. Now, certainly while that is adding an extra step, the reality is there are certainly many benefits to having these records, not the least of which from an administrator's perspective is having the record would allow for the generation of revenue. That's not my personal favorite reason, but certainly that's often our administrator colleagues' personal favorite reason. Next slide. The third recommendation is the delivery of targeted psychosocial support. Next slide. So first of all, support should of course be offered before transplant begins, but also repeatedly throughout the transplant trajectory. So in the setting of cell transplantation, for example, that 100-day mark in patients may be meaningful for caregivers to receive some support. Next. The results of all of the screening protocols should be used to triage caregivers to appropriate levels of care. Now, for so many caregivers, their distress results from the fact that they have absolutely no idea how to take care of the medical and nursing tasks that they've been asked to do. And so they shouldn't necessarily be referred to a psychologist for psychosocial care. They probably need to meet with a nurse. So it's very important to identify what types of needs are in existence and to really make sure that care that's delivered is targeted to caregivers' needs. Next. And we already have incredibly empirically supported interventions out there. Those we know already work to address anxiety, depression, facilitate coping, facilitate communication, such as the cognitive behavioral therapies, acceptance and commitment therapy. And so we don't need to reinvent the wheel. We actually have therapeutic packages we can draw from. Next, but in addition to these, we must also emphasize a focus on self-care and wellness, as well as social support, which is so limited for caregivers when patients move from that transplant period into recovery and survivorship. And for certainly many of our transplant caregivers, they are required to remain isolated at home. And so we need to help them to think creatively about how they can continue to cultivate social relationships and connectedness. Similarly, so many caregivers come to me into our clinic and say, I don't know how to speak to my loved one's healthcare providers. Am I allowed to speak with them? What are the questions I can ask? And we can do a much better job at providing communication skills training to caregivers, especially if we are basically asking them to serve as critical members of the healthcare team. Certainly, when we consider psychosocial support, it must include addressing existential distress and even anticipatory grief, especially for those caregivers of patients for whom transplants have not worked or whose illnesses are increasing and are no longer curable. And finally, we have phenomenal telehealth capacities right now, and we really should be relying on them to provide high quality psychosocial care when and where caregivers need it. They no longer need to physically come in to our therapy offices. Next slide. In terms of potential pitfalls here, so there, as I mentioned earlier, there is a limited availability of mental health professionals. One of my personal goals for my career is to expand the mental health workforce versed in supporting family caregivers. But one thing that transplant teams should be doing is creating a comprehensive list of community-based resources that they can give to caregivers so that they have support when they need it, even if there's a wait for someone on staff. There are phenomenal resources available through the American Cancer Society, the Cancer Support Community, the Leukemia and Lymphoma Society. I could keep going, I'll stop, but there's many out there, and many of these are free of charge and readily available. And transplant teams really should have a comprehensive list available and should be disseminating that to every caregiver who's enrolled. Fourth, next slide, is the recommendation for early and repeated education and training in medical and nursing tasks. Next slide. So Ira and Glenda did this so phenomenally. I love the idea that they sat down, they wrote lists of questions to have for their providers, but the enormity of medical and nursing responsibilities placed on caregivers' shoulders is one of the primary drivers of distress. And this is something that we can intervene on. Education should be delivered pre-transplant as well as repeated post-transplant into that recovery and survivorship period. Very importantly, caregivers need guidance in performing basic medical and nursing tasks. And I don't mean just giving a pamphlet. I mean having a nurse provide one-on-one training in how to do, for example, take one's blood pressure the old-fashioned way if that's being done, and then having the caregiver demonstrate that back and teach it back. Every caregiver should have the opportunity to train in this way before they go home so that they feel confident and competent to take care of their loved one at home. Next, caregivers really should be given training so that they know what to look out for in terms of potential complications, fevers and pain and signs of graft versus host disease, for example, so that they know what's normal and what's not and when they should be reaching out to the healthcare team. Caregivers should be given training and information about medication adherence and strategies to help their loved ones maintain adherence to their medication protocols. And finally, they need training around nutritional and metabolic support, especially because family caregivers are often tasked with making sure that their loved ones recovering from transplants, those with immune systems that are just in recovery, making sure that the foods that they're eating are not going to be harmful. This is a source of distress, and this is something that we can address. In terms of potential pitfalls and solutions, there are a lack of easily accessible evidence-based materials for training. For those caregivers who don't live near treatment centers and are located far away, there's a lack of resources for training them from far away. And then let's just name it. When you're initially in this role as a caregiver, the last thing you have bandwidth for is additional training. And that's very, very real. It's going to be important for us to capitalize when possible on asynchronous training modalities so that caregivers can take in information at a time that works for them, not when they're in the thick of a caregiving crisis. It's going to be very important for interprofessional teams to create a list of the top tasks that must be completed, that the most important things that caregivers need to know, and that this education is tailored to each caregiver. Ira is an expert. If Ira comes back to the treatment center, we do not need to provide Ira with basic training. Ira already has his honorary MD degree and his honorary NP degree. But there are caregivers who are new in the role and might need more support. And so we absolutely need to tailor the support to where caregivers are. And we should establish a schedule of check-ins. The team should be regularly checking in with caregivers to see whether or not they need more training or assistance, especially as patients move through their illness and recovery trajectory. And finally, final recommendation is very much reflected in the NAC report. I was thrilled to see this, and that is the identification of a family caregiver champion who's going to serve as a point person. And this recommendation really ties in recommendations 1, 2, and 3, and 4. So this is going to be one person on the treatment team who is going to be dedicated to the family caregiver, who's going to be the point person for communication, the point person for doing all of that initial screening and the repeated screening. They likely will be able to provide that training and medical and nursing tasks. And as well, that they may be able to provide the psychosocial support. You can go to the next slide. So some potential challenges with this is that we actually don't have any guidance as to who should fulfill this role. And if we think about the points on the prior slide and the recommendations here, this person likely needs to have expertise that crosses medicine and psychology and social work. Oftentimes in our healthcare systems, in our cancer centers, for example, there is a social worker who's identified as a point person for caregiver services. Whether it's a social worker or, for example, a psychiatric nurse practitioner who would have both the psychiatric and the medical expertise, having a healthcare system invest in one team member to be the point person for all of the contact with caregivers is going to very much mitigate the tremendous case management responsibilities that Ira and every other of the 53 million caregivers in this country have. These responsibilities are enormous, and we can do a much better job if we centralize this within one person on the team. Next slide. I'm going to stop there, but just say that I'm so thrilled to see this report. I'm also so thrilled to see that it's so in line with the recommendations of the 2022 National Strategy. And I think that everything that we're recommending is feasible. It's achievable. It's going to happen in the near term. And when it does, the experience of caregivers is going to transform dramatically, and we're going to see a very significant improvement in their quality of life. So thank you all for joining us today, and so excited to be here again.
Thank you, Dr. Applebaum, for sharing your perspective as a provider. We do have a few minutes for 1 or 2 questions. I did see comments coming in the chat about how this experience resonated, kind of the report, Ira's sharing of his story resonated with folks in the call. I haven't seen a question yet. But more
I see one. Okay. Yeah, I see one. It's a comment, but I think could be reframed as a question. So talking about the enhanced screening creating unintentional consequences of barriers for some patients, caregivers being screened out. And so how do you think we could take that into consideration, Dr. Applebaum, in terms of the impacts that enhanced screening could have?
This is such an important point. I'm so grateful. I'm not looking in the chat because I'll get distracted, but I'm so grateful for whoever asked it. Thank you for that. You're absolutely right. There is a necessity to have a family caregiver to consent for these transplants. And here we are saying, well, if we're going to screen and this person screens out, what do we do? This is where I think our healthcare system could do a better job in capitalizing on our volunteer services. All of our cancer centers have a robust volunteer program, and these are individuals who want to be helpful. And I think that if there's certain reasons why a certain family caregiver may not screen in, either they're unable to fulfill the role or unwilling to, we might think about training a workforce of our caregiver experts who are volunteers in our cancer centers and healthcare systems to help to step into that role when family caregivers are not available. And that could also, of course, be incredibly resourceful for those families where there is actually no caregiver available.
Great. I see a couple more questions coming in. They say, I see, this is very interesting from Michelle. I see this in students who want to come in a transplant doula, who want to come in to learn how to be a transplant doula. I had never heard about a transplant doula before, but I don't know if any of the other panelists had.
No.
Okay. Okay, one more
Uh-huh.
question from Kiku. I love all of these recommendations. What are the next steps and what steps can we take to make this a reality?
Yeah, I would just add one thing there because an exciting development happened since we finalized the report is that CMS actually finalized that rule around provider reimbursement for caregiver training services. So now there's two new reimbursement codes that healthcare providers and a really expansive list of providers can leverage to provide the kind of training that Dr. Applebaum underscored is important and that we underscore in the report as being important. So I think now the next step is, well, what do those trainings look like, right? Sort of really taking as many of the barriers out of the way of centers and providers around, how the reimbursement's there, the incentive is there, but we need to do more to educate centers and providers about these new codes and then the trainings that are available. And I think that's only going to be as effective as having the infrastructure that Dr. Applebaum's highlighted in place, the EHR, the screening process, so that we can make sure that the trainings that get provided are trainings that are actually needed and tailored to the caregiver.
Thank you for that, Jason. I think the question about what's next is an excellent segue to wrap up our webinar and our time here today. And so NAC will continue to raise the visibility of transplant caregivers and work to advance these recommendations. As Dr. Applebottom mentioned, these are actionable, these are practical, these are something that we can do together. This report is our first step in kind of building better support for transplant caregivers. You have the link here and a QR code. I encourage you to download it. I encourage everyone to share it with your networks, professional and personal, as we build a better systems and better policies and practices for transplant caregivers. And you have the link here. You can download it. I also just want to take the last few minutes to thank our supporters at Takeda, and also special thank you to you, Ira, for sharing your lived experience as a transplant caregiver, to you, Dr. Applebaum, for sharing your expertise with us, and to all of you for spending time with us this afternoon. You can go to caregiving.org again to access the report. We share widely. And reach out to us if you're interested in partnering with us and learning more about and working to address this really important caregiving community.
Thank you so much, all. Thank you, Yadira. Appreciate and excited about the future. So thank you all so much. Have a great rest of the week and happy Thanksgiving.